What I'm going to do today is take you through step by step through the disease that is called primary hyperoxaluria type 1, and then take you through the development of its new revolutionary drug that is called lumasiran. There are three types of primary hyperoxaluria known so far. It's type 1, 2, and 3. They are all affecting the glycoxylate metabolism in the liver. In each type, there is one enzyme that is either missing or defective. In primary hyperoxaluria type 1, it is the AGT that is defective. There. In primary hyperoxaluria type 2, it's GRHPR, and in primary hyperoxaluria type 3, it is HOGA, which is here. This is the liver cell, and the result of the lack of enzyme, and I'm referring now to primary hyperoxaluria type 1, is the accumulation of glyoxylate, because this enzyme is missing. Glyoxylate is accumulated because it cannot be metabolized to glycine, and then glyoxylate is metabolized to oxalate. So we have a rise of oxalate in the plasma and rise in the oxalate in the urine, resulting in insoluble calcium oxalate crystals in the kidneys. So we are talking about a very rare disease. Primary hyperoxaluria is found in 1 to 3 cases per million inhabitants, per million population. It is the excess oxalate that results in insoluble calcium oxalate crystals, leading to recurrent kidney stones, nephrocalcinosis, and kidney injury. Then, as the renal function declines due to the progressive disease, the oxalate elimination is further reduced, further compromised, and plasma oxalate increases. And in advanced disease, we have plasma oxalate in the blood that is deposited in other organs, such as the heart, and this is called systemic oxalosis, and it can be life-threatening. This is how the disease appears, and this is part of the heterogeneity of the appearance of the disease. So symptoms can appear in very young children, younger than 1 year, up to 10 years old. 1/3 of the patients that had their first symptoms at childhood, that's 1/3 of the patients have their symptoms at childhood, and 50% of these patients have already end-stage kidney disease at the time of diagnosis. Less than 10% of the patients that are diagnosed at childhood but still have a good renal function, a preserved renal function, they end up with end-stage kidney disease. 20 to 50% of patients are diagnosed at adult life. So let me be clear, this is not just a disease that is found in children. It is also, 50% is diagnosed at adult life. 52% of the patients who are diagnosed at adult life end up with end-stage kidney disease, which is opposite to the 26% that end up with end-stage kidney disease when the diagnosis is done at an earlier age, at childhood. 40% of the patients who are diagnosed as adults with preserved renal function will end up with end-stage kidney disease. And unfortunately, a large number of the adults are diagnosed after they have lost a graft, a kidney graft. 10% of asymptomatic patients are found at family screening after a person has been diagnosed in the family. And the disease, as we understand, has an overall high mortality of about 30%. So let me present to you now what are the signs, what are the symptoms, and how we can make and confirm the diagnosis of primary hyperoxaluria type 1. In this table, you can see how heterogenic is the pattern of the disease, because 35% presents as an infantile form, At 20% of the disease is presented as a recurrent stone disease in adults with progressive CKD. A 15% presents at a late adulthood, and another 15% of patients are asymptomatic, and they are diagnosed at pedigree at family screening. And the 10% are diagnosed after the recurrence of the disease at the graft. These are the signs of hyperoxaluria type 1 in children. First of all, stone passage, then nephrocalcinosis. Definitely these children fail to thrive. They may experience hematuria, dysuria, urinary tract infections. They finally get to have CKD or end-stage kidney disease. Similar in the adult population, recurrent kidney stones, nephrocalcinosis, chronic kidney disease, end-stage kidney disease, or other unrecognized general symptoms. So when we're looking at an adult, we're always looking for a patient who has recurrent nephrolithiasis, nephrocalcinosis, CKD with a low GFR, or acute kidney injury. Some patients present with acute kidney injury, or it could be a patient who's already on dialysis with end-stage kidney disease. But this is how frequent the symptoms present. The green bars is primary hyperoxaluria type 1. So it's mainly calculi, it's mainly nephrocalcinosis, it's mainly end-stage renal disease for hyperoxaluria type 1. This is a nice table showing the problems that occur with systemic oxalosis. So you can see the disease spares practically no system. It is the eyes, the vessels, the joints, the bone marrow, the bones, the heart, the thyroid, the teeth. All systems suffer when plasma oxalate is high and accumulated. What happens here is that the latest the diagnosis, the easiest, the most probable for the patient to end up with end-stage kidney disease. So diagnosis at adulthood is linked to a poor kidney survival. These patients reach end-stage renal disease. And the poorer the kidney survival, the lower the survival, the higher the mortality, the overall mortality of the patients. So this is finally life-threatening. What shall we look for in order to make the diagnosis in the adult population? We shall definitely look for a high oxalate in the urine. We shall look for a high ratio of oxalate versus urinary creatinine. We shall look for high plasma oxalate wherever and whenever we can measure it. And to do that, of course, we need a 24-hour urine collection. So if we suspect a patient might have primary hyperoxaluria, we need to perform a 24-hour urine collection. And we shouldn't forget to examine the stone. Sometimes we might even have the stone available before suspecting the problem. So don't forget to examine the stone. Why? Because when you examine the stone, 95% of the stones contain calcium oxalate monohydrate, is Weberite, and they have usually a pale-colored, a characteristic style and type. They cannot be confused with stones from idiopathic calcium stone formers because they usually have mixed calcium oxalate monohydrate and calcium oxalate dihydrate and calcium phosphate. We should also look at the urine. When you look at the urine, you might see the characteristic dumbbell, which I have here on top. This is the calcium oxalate monohydrate crystal. Make sure you don't have an ethylene glycol poisoning because these crystals can show up when you have that poison. Except from the dumbbell, calcium oxalate monohydrate can have the other forms as well, but they're more rare. Is urine sample diagnostic? So could you put the diagnosis just from looking at the urine sample? The use of urine sediment as the only means of diagnosing hyperoxaluria, primary hyperoxaluria, is not recommended, because even normal subjects, normal people, they make calcium oxalate monohydrate crystals, so you might end up with a wrong diagnosis. But what you need to do is combine, if you find the calcium oxalate monohydrate crystals in the urine, and at the same time you have a patient with renal function deterioration, then you should suspect and go ahead with further examination. Let's see at the characteristic findings in radiology. Ultrasound. Stones could be bilateral, but they could be also absent. There could be a patient who has already passed the stones. So what else are we looking for? We're looking for diffuse nephrocalcinosis. We are not looking for linear or dotted nephrocalcinosis, because that could be the result of prolonged hypercalcemia. It could be the result of an acute GN. It could be acute cortical necrosis. We're looking for diffuse pattern. So the higher cortex density should be diffuse in order to suspect primary hyperoxaluria. And these are characteristic images. To the left, you have just end-stage kidney disease, while to the right, you have cortical nephrocalcinosis in PH1 and medullary nephrocalcinosis. That's another option as well, also in PH1. Kidney biopsies, very characteristic findings, but you might not want to end up doing a biopsy, not necessarily. So you have crystals, oxalate crystals, which again are not pathognomonic, because they can be also found in kidney biopsies from patients with ATN or oliguria. Nevertheless, they're quite impressive, the way the calcium oxalate crystals have this appearance here and there, and how they're surrounded by giant cells and mononuclear infiltration. What else did we do in the past to confirm primary hyperoxaluria? We used to do liver biopsies, and that was the way you could look for the AGT and detect either its deficiency or its absence. And that was the best way to approach the issue. But what do we do today? Today we do genetic testing. We anticipate the genetic testing will go lower and lower in price, and it will be available widely. But this is the gold standard of diagnosis for primary hyperoxaluria today. We still have a huge problem. The problem is our delayed diagnosis. The 50% of the patients at the point of diagnosis, at the time of diagnosis, they already have CKD or end-stage kidney disease. And more than 20% of the patients are diagnosed after the disease has rejected the graft. Why is this happening? Of course, because it is a very rare disease, not just rare, a very rare disease. And also because we lack updated training. We, nephrologists, urologists, all the physicians, we are not aware of the latest guidelines. We do not perform complete evaluation, metabolic evaluation, when the patient has the indications. And we do not examine appropriately the stone itself. We do not measure oxalate in the urine in certain areas. There is no lab possibility there. And we do not investigate further cases of nephrocalcinosis. We just attribute it to CKD and go ahead with it. Of course, there is heterogeneity in the clinical presentation of the disease. No one says it's easy. And it's very easy to confuse it with secondary hyperoxaluria. There are tens of reasons that can cause secondary hyperoxaluria. So one has to exclude these reasons first and then go for the primary hyperoxaluria. And yes, there are diagnostic problems. There are no specialized laboratories. There are areas where plasma oxalate cannot be be measured. There is a normal daily fluctuation of oxalate excretion. So one could go in the gap and not hit the good result. So one needs to have multiple measurements. And there is false negative results. What should we do after we confirm the diagnosis? And at least this is the traditional, what we would call the traditional treatment. We would treat it as we do with every other type of stone, with the addition of pyridoxine, vitamin B6. All the rest is exactly the same, what we do for CKD patients and what we do for all stone patients. Just try to delay the time to dialysis. Try to relieve the patient from his symptoms and try to delay the time for the dual liver and kidney transplantation. When do we do the dual transplantation? When systemic oxalosis starts to appear, these are guidelines that are practically everywhere you can find. When systemic oxalosis starts to appear, and it's usually at a stage around stage 3, then you have to start thinking of the liver transplantation. And then, if this proceeds further down, then you have to go ahead with a double transplantation, liver and kidney. But fortunately, we live at the era of new therapeutics. And this drug has come to revolutionize the way we are perceiving and the way we're treating primary hyperoxaluria type 1 and hopefully other diseases. And I'm referring to the technique that is being used. And this is small, it's called small interference RNA therapeutics. This is a new class of medicines. These medicines, it's a natural pathway of gene silencing. What they do is that they target a protein, and they, by entering the cell and the nucleus further down, they prevent the synthesis of this protein that is encoded by that mRNA. So you silence a gene. In our case, the drug is called lumasiran. And what does lumasiran do? It blocks glycolate oxidase, the enzyme that transforms glycolate to glyoxylate. So there is no production of glyoxylate, therefore there is no production of oxalate, no accumulation of oxalate crystals. This is the sequence of the studies that helped develop lumasiran. And the studies are called Illuminate. Study Illuminate A, which is here, included patients over 6 years old, patients with an eGFR above 30, and it was young children and adults. Illuminate B was just for children, and Illuminate C is a study that was for all ages, and their GFR would be lower than 45. So it included patients with CKD and patients in dialysis. Let me say just a few words about the development and how this and the results of these studies. So this is the schedule of Illuminate A. There was a placebo arm and the lumasiran arm. This is the primary endpoint of Illuminate A. It was the % change in 24-hour urinary oxalate from baseline to month 6. The blue line is the patients who were on lumasiran. The purple line is the patients who were on placebo. And you can see there is a clear difference of minus 53.5 between the two groups, the two arms. And the mean maximal reduction was 76%. So I think these are impressive results. A rapid and sustained reduction in 24-hour urinary oxalate levels for the patients who were taking lumasiran. Illuminate A met its primary endpoint, and it also met all the tested secondary endpoints. And the secondary endpoints were also change in eGFR, that it was the proportion of the patients who practically normalized their plasma oxalate and their urinary oxalate. It was the percent change in 24-hour urine oxalate versus creatinine ratio. All these endpoints tested positively, favorably. In all subgroup analyses, the percent change in 24-hour urinary oxalate from baseline to month 6 was in favor of the group of the patients who were taking lumasiran in all subgroup analyses. And this is a very interesting secondary endpoint. It was the proportion of patients with 24-hour urinary oxalate lower than 1.5, the upper limit of normal, and lower than the normal. So it's practically the patients who normalized or nearly normalized their urinary oxalate. And you can see that 52% of the patients totally, completely normalized their urinary oxalate, while 84% of the patients reached a point near normal, which was lower than 1.5, the upper limit of normal, 1.5 times the upper limit of normal. When looking at safety profiles, there were no deaths, there were no severe, no serious adverse events. The only adverse event was mild, and it was some erythema, pain, or pruritus at the site of the injection. That was the only problem the patients faced, and there were no dropouts. Just a few slides for Illuminate C, which was the one that included dialysis patients as well, CKD and dialysis patients. And it's interesting to see that the change in 24-hour urinary oxalate values was very impressive, regardless of the level of urinary oxalate at the time of diagnosis. You can see that no matter where the patient started, would it be tertile 3, 2, or 1, this is higher, lower, and lower, they would all have a terrific drop, an impressive drop towards normal. The secondary endpoint, also a drop, a satisfactory drop in both groups, the dialysis and the CKD patients. And this is a total of the results of the Illuminate studies. The red bar, the red graph, is the placebo patients. All the other patients are the ones who were taking lumasiran. So they had an impressive drop in their levels of plasma oxalate. This is a very interesting index. This is renal stone events. I think it's very important clinically for us clinicians. So patients who were on lumasiran, this is their group. This is their renal stone events before starting the drug. This is their renal stone events after 6 months on the drug, and this is 12 months on the drug. So there was a significant drop in their number of renal stone events for the group that were taking the drug. And this is a comparison with a placebo arm. This is prior to 12 months. This is placebo, and this is lumasiran patients. So in all trials, there was a significant drop in renal stone events. And medullary nephrocalcinosis, it was found to be either stable or improved in all cohorts. And this is results from Illuminate C. Safety in Illuminate C, exactly the same results as Illuminate A. The most common adverse event was related to injection site reaction, nothing more. I chose this study, which is not Illuminate, because I think it has a very interesting clinical view for us clinicians. So John Liske tried to model the risk of progression to kidney failure, the risk of progression for those patients who were not on lumasiran and the patients who would be on lumasiran. In order to allow the estimation of the number of events that would be avoided with lumasiran, they developed a model of kidney failure risk as a function of 24-hour oxalate excretion, urinary oxalate excretion. What they show in this graph is that the red bar is patients who had the highest urinary oxalate excretion at diagnosis. And this is what happens with these patients at 30 years. The possibility of them to be free of end-stage kidney disease is very close to zero, as you see, if you take a line there. So this is the model they developed. And based on this model, they predicted the number of kidney failure events per 100 patients. And this is what happened. These are the number of kidney failure events. The blue bars is the patients that were not treated with lumasiran at year 10, year 20, year 30. This is a dramatic rise in their numbers of kidney failure events. While patients who were treated with lumasiran, they had an impressive stability and very low numbers in kidney failure events that were stable at year 10, 20, and 30. In conclusion, for the drug that is out now with able to be administered and prescribed in Europe, also prescribed in the US, and also in the European Association of Urology guidelines, urolithiasis guidelines, lumasiran showed that it can result in a substantial reduction, not only in plasma oxalate, but also in urinary oxalate for patients of all ages with primary hyperoxaluria type 1, with or without advanced kidney disease. Kidney stone events and nephrocalcinosis, they were found to be either stable or improved with lumasiran treatment. The most common adverse event was just the injection site reaction. So all these results definitely provide evidence supporting the general safety and effectiveness of lumasiran in lowering the oxalate burden of patients with primary hyperoxaluria. Dear colleagues, this is the disease, primary hyperoxaluria type 1, the very rare disease that we're dealing with, that overproduces and excessively urinates and excretes oxalate. We deal with recurrent urolithiasis and nephrocalcinosis and end-stage renal disease. Patients accumulate oxalate and leading to systemic oxalosis and life-threatening events with lower with lower survival, higher mortality. So what should we do? If we suspect it, we should proceed with genetic testing, because our overall goal is to achieve diagnosis as early as possible in order to start treatment immediately by using standard therapy and the revolutionary drug to lower the risk of CKD, end-stage kidney disease, and to increase survival in order to ensure the best long-term outcome for our patient. Thank you very much.
Primary hyperoxaluria, as Dr. Stamatou mentioned, is an overproduction of the oxalate that produce urolithiasis and nephrocalcinosis, that produce renal damage. The oxalate excretion is dropped, so we have deposition of oxalate in all tissues. The mode of inheritance is autosomal recessive. The clinical presentation is a flank pain due to the stones, about half of the patients, and hematuria, 1/3 of the patients. And we find nephrolithiasis on the half patients and nephrocalcinosis in the 1/3 of the patients. Oxalate can affect the joints, the retina, the skin, the bones, the heart, and the central nervous system. We have these nice pictures that we can see what oxalate does when it deposits. From the guidelines of urolithiasis of the European Association of Urology, we see that about 55% of stones come from calcium oxalate monohydrate. And at the diagnostic algorithm of the stone recurrence, we have the stone analysis of a stone that we can catch, and we have the stone analysis of an unknown stone. And of course, for the patients that have risk factors, we have a specific metabolic evaluation. Of course, primary oxaluria is a risk factor that is genetically determined, and also is the risk for chronic kidney disease very high. So the cornerstone of stone analysis and metaphysics of stone diseases, the stone analysis, and we do it with an infrared spectroscopy and X-ray diffraction. Equivalent results we have also from polarization microscopy, and the wet chemistry is deemed to be obsolete though. So in the basic workup, we have to take a good medical history and the physical examination of our patient. The first diagnostic imaging that we have to do is an ultrasound. We have some basic blood results, and of course the urine analysis. If we don't know the stone, we cannot catch it, we can add to that an enhanced CT scan, and also to measure the pH profile of the urine, and also a microscopy of the urinary sediment. And for the full workup, we need 24 hours urine collection analysis, that is 10 days apart from each other. And for patients, and the patients have to be stone-free for at least 15 days. Then we have to repeat it in 3 to 6 months, and then yearly. If we have a suspicion of pH, we should test oxalate, gluolate, the ratio between oxalate and creatinine, gluolate and creatinine, and HOG and creatinine. And now the morphology of the calcium oxalate monohydrate is it's a cream to light brown with a smooth surface, and out of the section we have a color like beige, as we can see here. Granular, and this is in a frequency of 0.4. The difference between the typical COM stone that we see is that the typical one is brown, and they have this section, and this picture in the electron microscope. The calcium monohydrate calcium oxalate monohydrate of pH1, it looks like this. We can see that there is a difference from the primary oxaluria type 1 to the primary oxaluria type 2, how we can see the stones. And of course, on the crystalluria, we see that the PH1 patients have this dumbbelled appearance in contrast with calcium oxalate dehydrate crystals. Patients with primary hyperoxaluria tend to form these stones, and which are demonstrated to be more resistant in shockwave treatment compared with the other stones. And on the CT scan, we see that the Hounsfield unit is about 1700 to 2800. That indicates that's a hard stone. So the epidemiology is, the prevalence is about 1 to 3 cases per million patients. It's one case over 120,000 live births in Europe, although in worldwide this increases in one case over 58,000. And the prevalence of end-stage renal disease is 1–2% in the pediatric patients in the US, in Europe, and Japan. And this increased to 10% in Northern Africa and the Middle East due to marriages between relatives. And of course, the end-stage renal disease is more than 50% in adults. The diagnosis is made before the age of 18, in a percentage up to 68%. The rest is in adults. The median age of initial symptoms begins at 5.5 years. And subsequent diagnosis is on the 11th year. The median delay in diagnosis is about 3 years. 20 to 50% of the patients present with advanced chronic kidney disease or even end-stage renal disease, and we find 10% after renal transplantation. These two Chinese, this kid of 3 years old that presented with nephrocalcinosis and this Steinstrasse here, and this is a 40-year-old patient that have deposit of oxalate in his retina and his joints and bones, and this is from skin biopsy. So the classification is of PH1 is infant type, early symptoms onset with renal calcification and renal failure. Child and adolescent type, adult type with delayed symptoms onset or renal disease. Some we find it after the transplantation, and of course we have the family type that we diagnose because another member of the family has a history. This is the diagnostic approach, and this is the criteria that we have to follow. So patients that have stones or nephrocalcinosis in the childhood, recurrent stone forms with calcium oxalate, or nephrocalcinosis, patients that have a family history, and patients with a chronic disease that have increased serum creatinine with calcium oxalate stones, and calcium oxalate deposit in the tissues and nephrocalcinosis should be our patients that we have to examine further, to investigate further if they have PH1. Up to now, the liver biopsy was the end point of our diagnostics before the genetic test. Now, in the therapeutic approach, we have conservative treatment, of course, hydration over 3 to 4 liters per day, vitamin 6, orthophosphate, magnesium, glucosamines, probiotics, and, if I may say, dialysis. Now, when to innervate? We innervate in children that have stones that are less than 4 millimeters. That they have symptoms that cannot be controlled, or they have signs of sepsis, or they have risks of permanent renal damage. Of course, larger stones, they need to be taken care of. Shockwave treatment with lithotripsy is effective treatment for adults and children, and it has a stone-free rate about 60 to 80%. However, for patients that they have PH, we have to consider some issues. The shockwave treatment, it produces interstitial inflammation and renal parenchyma hemorrhage due to rupture of small or to medium-sized arteries and veins, which usually resolve with potential for permanent renal scarring. Of course, we know that the shockwave is promoting a transient reduction of renal blood flow, and that is more profound in immature kidneys and diseased kidneys. Also, we have renal growth retardation in children with that has ESW treatment. At 1988, the two first patients that had children that have shockwave treatment, they developed renal function deterioration. And the results are not so good. We have a success rate of about 40% in 3 cohorts. And after the second treatment, it went up to 61. That is because, as we have mentioned, the calcium oxalate stones are resistant to fragmentation. And due to nephrocalcinosis, we cannot aim easily to the stone. The improvement of ureteroscopic instruments and the development of laser technology have allowed us for a safe and effective treatment of ureteric and renal stones. The smaller semi-rigid and flexible instruments have made our life easier by making easier the access to these structures, and the new laser technology is more efficient for stone fragmentation. So endoscopy is currently the procedure of choice that allows us a direct visualization of the stone. PCNL, of course, it's an effective and well-established method for removing renal stones, and should be considered for patients that have larger stones. And some have advocated that performing a PCNL using a smaller instrument is an effort to limit the neural injury. But studies have shown us that it's the same if you use a standard or a mini. The fractional loss of renal function is about 1%. Though if you use smaller instruments, we can access diminutive collecting systems in children. Now, the combination of retrograde approach with a flexible ureteroscopes and the percutaneous approach have merged the advantages of the flexible instruments and the percutaneous approach. The stone-free rate for PCNL is about 9%, and for intrarenal retrograde surgery is about 65%. So we can say that the combination is going to increase the success rate. The advent of shockwave treatment, and especially the ureteroscopic stone removal and PCNL, has dramatically decreased the performance of open surgical stone removal, and that applies also to laparoscopic approach. And the final treatment is renal transplantation or combination of renal and liver transplantation. Though the 6-year survival is about 84% to those patients that have renal transplantation, 56% that have the combination, and 50% for those that they manage with dialysis. Of course, in type 1, we have to perform transplantation, the liver and the kidney. In type 2, only the kidney, and thank God in type 3, this is not required.